and treatment. Thank you very much, Mr. Chairperson. Well, I prepared my slides in English and I could not translate them into Turkish, so please excuse me. The psychiatrists and the other physicians dealing with chronic diseases have a common problem, which is the sleep disorders. The psychiatrists, neurologists, and also specialists of chest diseases are interested in the sleep disorders. And sometimes they can also administer wrong treatments and make wrong analysis. Mustafa also said, for instance, sometimes the people are coming to us and saying that please prescribe me this drug, I have sleep problems. And also there can be periodic leg movements, restless leg syndrome, and insomnia, and the person gets antidepressant. Therefore, the progression is distorted to a great extent if there is a mistreatment. Chronic physical diseases are seen very frequently by all physicians. Therefore, we have to be interested, and it is absolutely necessary to correct the sleep disorders of these patients. I'm sure that the physicians will see more and more these patients because the population is getting older and older. And there are so many disorders that are caused by the sleep disorders, in fact. So first of all, the underlying reasons should be treated. But on the other hand, the sleep problems should also be treated. And if that is the case, then the prognosis is much better. But of course, when we say chronic physical diseases, of course, I cannot mention them all. But if we talk about them in general, Yavuz talked about a specific population and he talked half an hour. If I were to talk about all the chronic physical diseases, then I would talk until the evening. I would very much like to do that, but the Congress will not allow me. Of course, so I'm going to talk about these diseases very briefly. So, in chronic physical diseases, there are some symptoms that we see, and practically what kind of treatments should be administered. I will try to give you a kind of perspective. In Parkinson's disorder, we know that age-related sleep problems are seen, and specifically I'm going to talk about this disorder in specific populations. We know that 2% of the age population over 65 is suffering from this disease, and as the population gets older, we see more higher prevalence in Parkinson's disorder. 60% of them suffer from insomnia, and in approximately 60% of them REM sleep behavior disorder is seen, and excessive daytime sleepiness is seen in 30% of them. And together with the sleep medicine, they have even higher rates of daytime sleepiness. But in addition to that, sleep apnea, restless leg syndrome, and circadian rhythm sleep disorders are seen, particularly in dementia patients, Parkinson's disease patients. If they are old, then these symptoms are seen very frequently. You can see the relationship between the REM sleep disorders with neurodegenerative diseases. And you can see the prevalence of these symptoms. In some patients, we have multiple system atrophies. I think I'm going back.
Evet. Bazı hastalıklarda özellikle multiple sistem.
In some patients, particularly in multiple system atrophy, in almost all of them we see REM sleep disorders. I mean 86 or 90% of these patients do see REM sleep disorders, and Parkinson's disease patients, up to 60% of the patients suffer from REM sleep disorders. And for instance, REM sleep disorders are seen and there is no Parkinson's disease symptoms, but 6 months later or 2 years later, the person can go to see a neurologist as a Parkinson's disease. So we need to work in collaboration with neurologists to identify the treatment for these patients. Here you can see the daytime and night time for the sleep histogram of a patient. In A, we have a normal histogram. There are stages 1, 2, 3, REM, non-REM periods. There's a normal pattern. However, in B, there is a Parkinson patient. Chromotriptan and levodopa is used by this patient, and there is a daytime sleepiness that is increased. In addition, here there is a hypnagogic hallucination, particularly after the drug administration. There is a hypnolytic hallucination. And also in C, we have moderate Parkinson's disease patient. The daytime sleepiness is increasing, and after levodopa use, 3 or 4 hours of sleepiness is seen, and also the drugs are also affecting the patients being separate from the diseases. This is a Parkinson patient, but he is very severe. There's major akinesia, food dystonia, and also together with the other behavioral distortions, the sleep is completely fragmented and distorted. As the treatment, well, as basic treatment, we have the dopamine regulation that should be ensured very correctly. So if dopamine is high or less, then sleep disorders are seen. So if there is high, then hypersomnolence can be seen, and if there is less, then the sleep quality will be reduced. For insomnia, there are some studies carried out. Zolpidem, clozapine, quetiapine, and also many other drugs are already mentioned. And also related to insomnia, first to secondary factors should be eliminated. And this was already mentioned, that's why I'm not going to spend a lot of time on this. Sleep hygiene, elimination of secondary factors are very important. There can be prostate, because these are old patients, depression, psychotic manifestations can be seen. So therefore, the underlying reasons should be eliminated, secondary reasons should be overcome, and then a treatment modality should be adopted if there is insomnia in the patient. Then non-benzodiazepine drugs are more recommended. Zorbidem, clozapine, quetiapine. Although quetiapine is not recommended very much, but we can use the low doses of quetiapine. In many depression patients, antidepressants can worsen the pre-existing restless leg syndrome and REM behavioral disorder. This was also mentioned by the previous speakers. I don't want to reiterate them. And also for the REM behavioral disorders, some drugs like clonazepam, melatonin can be used. You know that REM sleep, the REM behavioral disorder is seen when the REM sleep is distorted. We know that the eyes are atrophic, and the other muscles, only the eye and respiratory muscles are activated, and the other muscles are just flat line. But sometimes there can be behaviors during the REM period, even to an extent where the bed partner can be damaged. So clonazepam and melatonin can be effective in the RBD cases. Modafinil is used for daytime sleepiness. And it can be used also as a psychostimulant. Methylphenidate is also used for that, and it is well tolerated according to some studies. Restless leg syndrome or periodic limb movement was already mentioned by the previous speakers. These are very frequently seen, and this represents 3% of the population. Prevalence is quite high, and we can also see them together with secondary factors. Daytime sleepiness is also seen in these patients because the patient cannot have a high quality sleep during night. Restless leg syndrome has a circadian rhythm. Most of the time, before going to bed, the person is in need of moving his or her legs, and also there is numbness. And together with the person sleeping with him or her, they are deprived of the sleep. Some dopaminergic agents, opiates, and also benzodiazepines can be used. The recommendation is a step-by-step approach. But most of the time, dopamine agonists are used. Pramixapol or ropinirole is used because they have 24-hour effectiveness, although they are not available in our country. Pramipexole is also recommended in these situations, and also as dopamine agonists, we use prandixole, and if it is not useful, then we actually skip one of the steps and we use benzodiazepine and anti-epileptics. Pregabalin is used most frequently, and it's quite useful because the sleep quality is increased and the restless leg syndrome is relieved a lot. For Alzheimer's disease and other dementia patients are already mentioned by the previous speaker. So the sleep is usually fragmented, and slow wave sleep is decreased. REM sleep may be reduced. The treatment of these patients is very important from that aspect, and clinicians should treat them very effectively. Here was already talked about this issue, so I'm going to skip this. And for insomnia, trazodone is very cheap, and we benefit a lot from trazodone. It's very effective in insomnia in this patient population. For restless leg syndrome, again, pregabalin, pramipexole can be used in combination. Excessive daytime somnolence requires the use of modafinil and methylphenidate. And for REM sleep behavior disorder, clonazepam and melatonin are recommended. It can cause some benefits. And for psychotic features, behavior discontrol, strolling around in the night without any aim, can be also the indication for anti-dementia, antipsychotics, and antidepressants. But of course, we should be careful for the mortality risk. And some other drugs can also be used in this patient population. So we talked about the neurologic diseases, but most of the time there can be cerebrovascular event-related, epilepsy-related, many other disorders. I cannot mention them all because of my time limitation. I just try to give you a perspective. For asthma and chronic obstructive pulmonary disease, about COPD, these patients do have very serious sleep problems because they have nocturnal cough, wheezing, and breathlessness. Also the O2 saturation is quite low in these patients. If there is O2 saturation decrease, and if there's sleep apnea, then so many pathologies are seen in these patients. Together with the carbon dioxide pressure, there's the end organ dysfunction, endothelial dysfunction is seen, pulmonary vasoconstriction, and together with sympathetic activation, fragmented sleep is distorted once again, and there are some also other adverse effects. And together with the pleural pressure, there are also problems with the lungs. So these are sleep apnea. I mean, these are seen as a result of the drop in O2 saturation. So without knowing the pathophysiology, you cannot determine your treatment. And in the end, there is a long list of symptoms and consequences of this sleep apnea: endothelial dysfunction, hypertension, dementia, and sudden death. These are various pathologies that we may face. Asthma attacks and sleep times are compared in this study, particularly in stage 2. We have high prevalence. The stage 3 and 4 are suppressed. Normally, stage 4 should be 13 or 14%, but it's suppressed to a great extent. That is, the sleep which relieves the patient, which relaxes the patient, is decreased to a great extent. That is why the patient has dysfunctionality during daytime. So the asthma attacks are seen in almost all of the stages. Therefore, firstly, the asthma attacks should be treated. About the O2 saturation, if it is low in asthma patients, in fact this is a very well-known fact, they cause some problems. And in treatment, you can see that we have steroids and beta agonists that are used for the optimization of the treatment. Oxyhemoglobin is also shown in the COPD patients, and CPAP treatments should be given continuously, and positive airway pressure, that is the CPAP treatment, should be given to the patients in order to increase the O2 saturation. And also MT1, MT2 receptor agonists should be used, and it's very important because they do not distort the gas exchange of the patients. Benzodiazepines cannot be given very easily to these patients because there is already a respiratory depression, and if you intervene together with a drug, then there will be even increased risk. Therefore, MT1 and MT2 receptor agonists are promising for the future. About the cardiovascular system, we know that it's approximately 1/3 of the population. Coronary artery disease, heart failure, these are composing 1/3 of the population, so it is an important population, and they do have serious sleep problems. The pathophysiology is also impacted, and they cause heart diseases, and they can cause even death. Therefore, the underlying main reasons should be regulated first of all. And CPAPs should be used, as I said before, and also benzodiazepines and alcoholic beverages should be avoided in these patients. Your last 5 minutes, sir. Cancer patients complain about fatigue. It's a very important problem for these patients. And during the day, they are very tired. And not only chemotherapy, radiotherapy is causing this daytime sleepiness and fatigue, but also the sleep disorders are causing this daytime fatigue of these patients. As treatment, pharmacologically, we have sedative hypnotics can be used, and I'm not going to get into details. It was already mentioned for insomnia, and psychostimulants for fatigue can be used, and psychosocial treatments can also be used. Activity-based interventions and bright light therapy can be used. Bright light therapy is an important therapy that can be used in this patient group because these patients already use polypharmacy. They take so many medications, and their medications are quite intense. So bright light therapy is quite useful without any more intervention. It has a very simple apparatus. We brought this from abroad, and it's cheap, and it has great benefits. And if the patient cannot use another medication, or if you do not need the medication in that patient, this bright light therapy is quite useful. Fibromyalgia is something that is ignored very much. The physical therapy experts can make the diagnosis, but most of the time we ignore this diagnosis. If there is musculoskeletal pain for more than 3 months, we need to think about fibromyalgia. And if we have sensitivity in these 11 11 parts, 11 sites, then it's enough to make the diagnosis. Fibromyalgia causes very serious sleep disorders, and there are important characteristics. First of all, we have a sleep which does not relax the patient. So the sleep latency is protracted, and also the slow wave sleep is reduced, and REM period is also shortened. And EEG activity is also seen like this. I think it should be stage 3. And in the end, the sleep is not actually comforting or relaxing the patient. And these patients have serious problems in cognitive functions during daytime. Hypnotics do not provide any good in the treatment of these patients. Previously, tricyclic antidepressants were recommended, and I still use them. SNRI, duloxetine, milnacipran can be used for fibromyalgia, and they are approved by the FDA. And pregabalin is also used in this patient population. We also have tricyclic antidepressants, non-benzodiazepine hypnotic drugs like zopiclone, Imolan. They can also be used. Antihistamines and chlorpromazine are not used very frequently because of the fever effects. Sometimes if we switch the patient to other drugs, maybe we can use them, and dopamine agonists are also used in this patient group. For endocrine disorders, we have various patient groups. Because of the metabolic disorders, they have very serious sleep problems. In gastrointestinal disorders, the gastroesophageal reflux is distorting the quality of the sleep, and also the non-REM period is reduced in some other conditions, and the slow wave sleep is decreased, and non-REM period is increased. And we need to have a symptomatic approach. I'm concluding. As a result, we need to minimize the underlying reason, and also we need to treat the underlying reason of the physical condition. Sleep hygiene is very important for us. We need to pay attention to the sleep hygiene, and first we need to treat the patient for sleep hygiene. That will have more benefits for the patient. I hope that you did not fall asleep. And this is my last slide showing the person who does not have a sleep hygiene.